This is the theory component of the Nursing 101 lab number 2. This PowerPoint includes all the theory components behind mobility, nutrition, and bed making that you will need to know for this week. So the first part of the theory that you guys will be expected to know is regarding nutrition. So first we have anatomy and physiology of the digestive system. So each part of the GI system or gastrointestinal system has an important digestive or absorptive function. The epiglottis is a flap of skin that is between the esophagus and the trachea, and it closes over the trachea when swallowing, and this prevents aspiration. Aspiration is the medical term used for choking. Dysphagia is a term used when referring to difficulty swallowing. So when we break the term dysphagia, dys, dys means difficulty, and phagia is the medical term relating to swallowing. So dysphagia is difficulty swallowing, and this can put a patient at risk for aspiration. Having the foundation of what the anatomy and physiology of the digestive system is, so what it looks like and the purpose of it, is important when we consider the nutritional status of patients. So what is a nurse actually looking for in terms of nutrition with their patient? We went over what an aspiration risk is. So an aspiration risk is a patient who is at risk for choking, and this is commonly related to dysphagia. Dysphagia is characterized by delayed swallowing. The patient might have challenges swallowing or be unable to swallow altogether. They might also cough after having anything to eat or drink. This is a very common indicator that the patient might have difficulty swallowing or dysphagia. We need to take into consideration the patient's allergies and make sure that it is well documented so that the patient is not accidentally exposed to any allergens. We need to look at the patient's appetite. We need to consider the amount of intake that they're actually having and compare this with their appetite. So do they have a good appetite? Are they having good intake? Or are they not having any appetite and not really intaking anything? And in terms of intake, we need to consider fluids and food, as both of these have significant implications on a patient's health and well-being. Food preferences, as we know, hospital food is not always the most delicious or appetizing, so it's important to consider what food the patient actually prefers. Dietary staff typically comes up to the wards and asks patient for their dietary preferences, which is a great way to actually encourage people to eat, especially since people who are in hospital typically have decreased appetites. Patient's weight is always an important factor to consider. Their posture in bed. So is the patient laying flat? Are they slumped over? Are they rolled to one side? I'm assuming everybody realizes that it's kind of hard to drink something or eat something when you are laying flat in bed. So taking into consideration what the patient actually looks like when they're getting ready to eat is very important. LOC stands for level of consciousness. If a patient is sleepy and not responsive, it would be considered unsafe to feed them for obvious reasons. We don't want them to be at an aspiration risk. Patients that have decreased LOC are unable to follow direction, and direction is very important when you are setting up a patient to eat. LBM, or last bowel movement, so is the patient excreting waste as they should be? This is a common assessment question, an assessment that is important to take because we need to make sure that our patients are regular. Taking into consideration diet orders. So there are a different variety of diet orders based on what the patient is admitted with and any considerations that we need to take for each patient. So DAT stands for diet as tolerated. This would be for any standard patient that doesn't have any dietary restrictions. NPO means nothing per oral, so this patient is to have nothing, fluid or otherwise, by mouth. And the reason a patient might be NPO, they might be waiting to go for surgery, and we want those patients to have nothing in their belly that they could potentially aspirate on. Or the patient might be at a risk for aspiration, and so we are actively avoiding feeding them so that they do not aspirate. Heart healthy diets, I think, is pretty self-explanatory. Low sodium is kind of related to the heart healthy diet, so decreased salt, decreased fat consumption, increased protein. Pureed diets are food that is pureed. This is for patients that have challenges with mechanical aspects of their digestion, so the inability to chew properly. They might be missing dentures, they might be unable to chew and swallow safely, and so we give them pureed food. Thickened fluids, again, this is for patients with a risk of aspiration. Thin fluids can sometimes cause a high risk of aspiration for patients, and so we give them thickened fluids. Clear fluid would be patients that are ordered a clear fluid might have pancreatitis, they might be preparing for surgery, and clear fluid is any fluid that you can see through. So apple juice is considered a clear fluid, water, simple soup broths, that kind of thing. Mechanical soft is on the same trajectory as a pureed diet. It's kind of a step up. This is going to be foods that are easy to chew for the patient. And then, of course, a diabetic diet would be a diet that is safe for diabetics to have. It's also important to consider any aids that the patient might have. Do they need to wear glasses? If they cannot see their food, they probably won't eat their food. If they can't hear when the trays or their food comes into the room, also going to be a problem. So if they have hearing aids, it's important that they have those in as well. Another consideration would be dentures, and I think this is probably the most important one in terms of eating. Patients can't eat if they don't have their dentures. There are multiple circumstances when a patient might have lost their dentures or misplaced their dentures, and if this is the case, then we need to maybe change them from DAT to a mechanical soft diet so that they can chew their food without their dentures. If you determine that a patient needs assistance with feeding, and there are patients that do need assistance, there's some things to keep in mind. Bibs. We don't use the term bibs simply as it can be a little bit demeaning, and I think kind of violates the dignity for our patients. So we use the word shirt protectors when describing a bib for a patient, and it's ideal to use these for patients that might spill, just to keep their gown nice and clean, and that way we don't have to change them after every meal. When you are feeding somebody, waiting 5 to 10 seconds in between each bite or sip is ideal. You will wait longer for somebody if they have any type of dysphagia. Also, when you are offering bites, it's ideal not to hover with the next bite for the patient, as this can cause rushing and then increases the risk of choking. HOB, head of bed. So it's important that the head of bed be elevated, typically 45 to 90 degrees, or high Fowlers would be the ideal position for feeding a patient. You want them straight up in bed, considering their posture, they should be straight. And we wanted the head of the bed to remain upright for a minimum of 30 minutes after eating so that the patient does not regurgitate or aspirate. If the food starts to come back up, it increases the likeliness that the patient could aspirate. So important things to consider. Patients with dysphagia might pocket their food, and this indicates that they sweep their food into the corners of their mouth and fail to actually swallow. So checking in between a couple bites to make sure that all the food is actually cleared from the patient's mouth is good practice. Also, oral care. Best practice is to do oral care after each meal, especially if the patient has any dentures or any kind of dental work of any kind. But all our patients should really be getting really regular oral care, as oral care is a direct indicator of cardiac health. So maintaining good oral health, it maintains good heart health. Bad oral care can actually increase the risk of heart disease. So now we're moving on into mobility, immobility, and skin integrity. So just like when we started the conversation around nutrition, there is a certain knowledge base that needs to be there before we can talk about anything else. So these are the common terms and abbreviations that you'll need to actually understand in order to work with patients and other healthcare professionals in relation to patient activity, mobility, and immobility. The first term on this slide is body mechanics, and this term is directed at you. So always protect your back. Always be mindful of the body mechanics you are using when working with patients. If you are rolling a patient around in bed or providing care to a patient while they lay in bed, move the bed up to your hip level or a comfortable working height for you and your partner. It is so important that you are mindful of your own body mechanics, being mindful of how you reach over patients, how you twist and turn, and how you lift, always using your legs to lift and not your back. At all costs, always protect your back and your body. ROM stands for range of motion. We will get patients to do active and passive range of motion exercises. Physiotherapists are also a great resource to help us do this with our patients. AAT means activity as tolerated. So physicians typically give us an order on the activity level that the patient can do. So activity as tolerated would be that a patient can do anything that they are able to do activity-wise. Some patients, however, are ordered bed rest or non-weight bearing status. NWB would be non-weight bearing status. This might be patients that have a hip or knee or leg injury of some sort, and we need them to stay off of that leg, or if we need them to be on complete bed rest, they are completely non-weight bearing. Patients that are immobile, we need to consider their risk of skin integrity damage. We also need to consider how often we are moving them around. So immobility is the impairment of mobility. Gait is the way that a person can walk. So a steady gait would be somebody that is standing upright, good posture, strong legs, walking one foot in front of the other. An unsteady gait might be somebody that is dragging a foot, maybe if they've had a stroke. If a patient has Parkinson's, they might be shaking and only taking really small, shuffly steps. These would be considered unsteady gait, and this increases the risk of patient falls, so important to consider as well. Activity tolerance is the duration in which a patient can handle activity. A decubitus ulcer is the medical term for a bed sore. Now, bed sores happen in relation to pressure. Pressure injuries happen when three things are kind of compromised. So pressure intensity, so lots of intensity on one point of pressure. This pressure is for a long duration of time, and the tissue is unable to tolerate it. So when these three things combine, that's when we start to get pressure injuries or decubitus ulcers, also known as bed sores. Moisture is also a culprit in the formation of bed sores. Constant moisture on the patient's skin can decrease tissue tolerance and contribute to bed sore development. Nutrition, if a patient is malnourished, they are more likely to develop bed sores, and if they do already have a bed sore, if they are malnourished, they are at higher risk for not healing or having challenges with healing. Perfusion, we need oxygen and blood to be flowing in order for tissues to get oxygen. So we need our perfusion to be getting to these areas, and this is why when we have pressure, intensity, and duration, this impacts the perfusion or decreases it, and this is what causes bed sores. Comorbidities are also important to consider. Patients with diabetes are at risk for impaired wound healing. Patients with immobility, so anything that might impact mobility status, would also be at risk for impaired mobility or pressure injuries. Blanchable is a term that is used when we see redness on a common pressure point. We will push on it to see if the wound or patch of red skin, erythema, turns white. If the assumed wound turns white, that indicates that there is perfusion and blood flow underneath. If the sore stays red, that indicates that there is tissue damage underneath and there is not adequate perfusion to the wound. The Braden scale is a tool that is used to determine the risk of impaired skin integrity amongst our immobile patients and mobile patients. So we look at their sensory perception. This is their ability to recognize discomfort and actually verbalize that. Mobility, their ability to get up and move independently. Their level of consciousness, so if they are unconscious, they are going to be unable to move at their as they wish. We are going to have to significantly help them with that, and it's especially important when considering pressure injuries. Shear and friction. Shear is and friction are factors that increase the risk of skin tearing. So we think of boosting patients in bed. If they are constantly sliding down the bed and we are constantly boosting them, that increases the shear and friction on the patient's skin and increases skin breakdown. Moisture, like I had mentioned before, moisture is a culprit in impaired skin integrity. When moisture sits on the skin, it can cause some significant damage. And nutrition, as I mentioned earlier, if a patient is malnourished, it is going to be very challenging for them to heal, and they are at higher risk for impaired skin integrity. These two pictures here show the common pressure points. So the picture on the right shows the common pressure points when a patient is laying on their back, in a wheelchair, or on their side. And this is why we rotate patients, is so that we can alleviate these common pressure points. These are also the most common pressure injury sites. So important to recognize why we need to roll our patients and how we roll them. On the left is the Braden scale, and like I had mentioned in the previous slide, this looks at things like sensory perception, moisture, activity, mobility, nutrition, and friction and shear. So what we do is we assess our patient in each of these categories and we scale them numerically based on the scale on the sheet, and then we tally it up and make a score. If a patient is between 15 and 18, they are considered low risk of impaired skin integrity. 13 to 14 would be moderate risk, and 10 to 12 is high risk. Less than a 9 would be very high risk for skin integrity, and it notifies us as nurses that we need to take extra precautions to make sure that we maintain this patient's skin integrity. Common bed positions. These are important terms for you to know. This is directly out of the textbook. The first position there is Fowler's, and so this is when the head of the bed is 45 degrees or more. It's kind of a sitting position. Some patients like their head of the bed elevated just a little bit, and this would be like a Fowler's position. It promotes lung expansion and is preferred while the patient's eating. I would argue we almost want it up at 90 degrees, closer to 90 degrees if we can, if the patient is eating. Semi-Fowler's is when the head of the bed is about 30 degrees, so it's a little bit less. Again, used with feeding, it reduces the risk of regurgitation. We just need that head of the bed elevated to prevent the risk of aspiration. Some patients also like this level of head of bed when sleeping. Trendelenburg is when we put the head of the bed down, so we tip the patient on their head. We use this position when boosting patients in bed. It allows gravity to do some of the work for us. We also use this for multiple reasons. Postural drainage, so if somebody is having a vasovagal response or a fainting episode, if we put them in the bed with their head down, it allows the blood flow to go to the head and the heart, so allows the heart to not have to work as hard to get that blood to the essential organs. Reverse Trendelenburg's is not used very often. It's when we put the foot of the bed down. Again, not used super often. If we need the patient's head above their feet, we'll normally just set them up into Fowler's or semi-Fowler's position. And we have flat, and this is just when the patient is supine and the entire bed is completely flat and horizontal, parallel with the floor. One of the last things here is safety. So as I mentioned in a couple slides back, body mechanics, super important that you always take into consideration the way that you approach a patient. If the bed is in the lowest position and you need to work with the patient, raise the bed up so that you are not bending over. Also be mindful of any twisting or turning that you might be doing. Make sure that you're putting yourself in a safe position to do so. Don't hurt yourself. What do you do if a patient starts to fall? As awful as it sounds, when a patient starts to fall, you move out of the way. I know it's really hard to not try to catch a patient as they're falling, but if a patient starts to fall and you try to catch them, you are almost guaranteed to hurt yourself. There are certain circumstances, and this will be demonstrated in lab, there are certain circumstances where you can put one leg in between the patient's legs and kind of glide them down to the floor if they start to fall. However, we do not want to catch patients. This is not safe, and as I said, it is almost a guaranteed musculoskeletal injury, so you need to protect yourself. Bed rails, when working with a patient, always make sure, if you are working with a patient independently, always make sure that the opposite bed rail from the patient is up, so that if the patient goes to the other side facing away from you or rolls away from you, that the bed rail is up and they won't fall out of bed. Always making sure when you leave a patient that their call bell is in reach. Bed height, so like I said, always important for your body mechanics to move the bed up to hip height or comfortable working height before you provide care, but the bed height needs to be put back down to the lowest position before you leave the patient. And lifts. We are going to go over the mobility decision and support tool. It can be found on the Nursing 101 lab Moodle shell. But this is a tool that allows us to determine what kind of lift we need to use. There is a variety of lifts, all that will be reviewed in lab. Galvo and ceiling lifts are the biggest lifts that we use. A Galvo lift is essentially a ceiling lift on wheels, but ceiling lifts are used to take the entire weight of the patient, whereas lifts like a Sarah or a Sabina lift require the patient to have some sort of muscle tone and ability to stand on their own. So determining which lift to use is a skill, and we will go over that more in lab. Have a look at the mobility decision and support tool, as this will also help you determine which lift to use. So that is it for the theoretical components of lab for next Monday, so next week, lab number 2. In lab, we're going to practice feeding each other. We're going to practice doing lifts with a variety of different lifts. So we will see the Sabina lift, ceiling lift, Galvo lifts. It is really important that you know in the clinical setting, you are to never do any kind of lift without the direct supervision of an instructor. So for safety reasons, you always have to be supervised by your instructor whenever doing any kind of lift. Mobilization is very important for patients, and we need to make sure that we are doing it safely and properly so that the patients don't get hurt, but also so you don't get hurt. So lab is going to consist of a lot of practice time this week. There'll be some quick demos and a lot of practice. So make sure you have a look at the textbook, highlighting the boxes for reading as found in the syllabus, and we will see you in lab on Monday.